Hello, everybody. Thank you for attending Establishing a Successful and Effective 23-Hour Stay Program. This is Dr. Joel Buchalter, and I'm Danilo. Just a little background for the two of us here.
So I'm an orthopedic surgeon. I trained at New York University School of Medicine, did my orthopedics at the Hospital for Joint Diseases, which is now called New York University Orthopedic Hospital. I have been in practice for 30 years. I am the founding partner of Somers Orthopedic Surgery. I specialize in joint replacement, hip and knee replacements, as well as shoulder replacements, and have worked the last couple of years very closely with Danilo.
And again, my name is Danilo Duprile. My background has been primarily in ASC operations and development. I developed the surgery center in Danbury, Connecticut with Dr. Buchalter and the Somers team. And I currently work for Merritt Healthcare. I work in development, ASC development, and I also have prior experience in medical practice operations, specifically in orthopedics and hospital physician hospital management. So to give you a brief, just a timeline of our center in Danbury, the Orthopedic and Specialty Surgery Center, which we typically refer to as OSSC. We opened our doors in 2019 for patients. That was March of 2019 that we began seeing patients. We're located in Danbury, Connecticut. It's beautiful, as you could see on the left here. It's a beautiful building and beautiful location right off the highway. And Dr. Buchalter's practice is on the lower floor as well. So we started our first cases in March of 2019. Move on to 2020. We were getting really busy, and then obviously in March, at the end of March, we decided to make the tough decision to stop cases because of COVID. And we were only doing, for about a month and a half, we were only doing urgent cases. We resumed at the end of May with full schedule, and from that point, our volume took off. And a few reasons for that. One, we had some additional payer contracts, but mostly, we had such an influx of patients that we were treating because of the shutdown. And then fast forward to 2021, obviously this has been our best year yet at the surgery center, and we have far exceeded projections when it comes to total joint replacements, spine, and other surgeries. I will say we are a multi-specialty surgery center, so we're not just orthopedics. We have ENT, urology, plastic surgery, and pain management. So just a brief overview of what we'll be discussing today. We're going to talk about what is a 23-hour stay program, coupling that with a total joint replacement program at the ASC level and how that gets started. Regulations around the 23-hour stay program from your state, federal, and accreditation levels. Who are the key stakeholders that the program impacts? Establishing your protocol, how to go about that, and where we found the components to put that together. Your staffing, your surgeon's perspective, and then we'll finish with financials and statistics. I think that's probably the thing that everybody wants to see.
So I guess, it's my turn. So, we split this up in a way, clinical and administrative, and kind of will combine things as we go. But the big question is, why did we develop this 23-hour stay program when it seems around the country this joint stuff is more outpatient, get your patients home, same day surgery. So it's sort of a genesis of this, in the hospital, several years prior to developing the surgery center, I began dabbling with outpatient joint replacement. So it goes back about 5 years ago total. So we began by identifying patients that were good candidates for outpatient surgery. We established protocols for discharge. We kept the patients in the ambulatory unit and tried to avoid to send them up to the surgical unit because, as soon as they got to the surgical unit, they're in their pajamas and they had a nice lunch. They're taking a nap in the afternoon, and you see them later in the day and they say, "Doc, I just think I'll stay. I'm already so tucked in and comfortable." So we said we got to keep these people in ASU, treat them like an ambulatory case, like a ACL reconstruction. We did have failures. Some of the failures were related to nausea or pain control, or just fear, just fear of going home. Sometimes it was the patient, sometimes it was the caregiver that was afraid. Those patients invariably went up to the unit and spent the night. But by the next morning, they were ready to go home. They could have gone home 2 o'clock in the morning or at midnight. They were comfortable at that point and ready to leave, and the caregivers were comfortable. So we realized there were a proportion of these patients that, were not great candidates for going home the same day, but were great candidates for a 23-hour stay. So at that point, when we were developing our surgery center, we said, we should have some beds available for this 23-hour stay. And then the other issue was, we have other docs that, dabble in joint replacements, and they're not comfortable sending their patients home, but they would be comfortable with keeping them overnight. And those things would add to our volume. So in the end, when I went through all the stuff that we were doing, probably 80% of our patients were patients that were either candidates for outpatient surgery or just a simple 23-hour stay. And that's a ton of patients. So from there, we started our 23-hour stay program in July of 2019. And because of Danilo's work, we were the first center in Connecticut to establish a 23-hour program. And he'll go into how he was able to do that, because there was a lot of regulatory work and creating a program that never existed before. So presently our capacity is 3 patients per night. And that seems to work very well because, as a joint replacement surgeon, you could probably do 5 or 6 joints a day. And, that includes the couple that you would keep overnight and the couple you would send home. So again, the success of this was really establishing this program in a hospital setting. And that's what made it successful, moving it to the surgery center.
Right. So what is a 23-hour stay program? There's many definitions. I tend to shy away from referring to it as inpatient, because it's not inpatient. As Dr. Buchalter said, these are patients who are ambulatory. They should be treated as such. And they're just having an extended time period in the ASC overnight for comfort reasons, or for, could be any other reason. But as defined by AAAHC, a program would be an incredible ASC that has patients that are not discharged from the facility on the same day that they were admitted to the facility. And then we'll get into what that means for CMS as well. So again, what is a 23-hour stay? It's a system in place for patients to be able to stay at the ASC, not to exceed 23 hours and 59 minutes. That is defined in the CMS guidelines. You must have a good developed protocol that governs the program, and that outlines policies and procedures for the overnight care. Each state may be different. Some states may have regulations around a 23-hour stay. We found in Connecticut that the state, because they had not had an ASC with a program already, and we were the first, we were able to present a protocol to the Department of Health in Connecticut and get their approval. Again, each ASC may have a different set of protocols and requirements based on their state's guidelines, or the way we do it may not be the way others do it, so that they can vary ASC to ASC. And again, to reiterate the fact that having an established total joint replacement program and or a spine program that allows you to, you're not working on the two things simultaneously. You want to have the total joint program established in order to move forward into establishing a 23-hour stay program.
So there are certain benefits to the program, which I'll speak to, and then Danilo will speak to the drawbacks and how we mitigated that. Certainly volume is a big thing. Yeah, as you'll see later on, that our volume has increased dramatically, and our volume is so much higher because we do the 23-hour stays. The increased volume obviously results in an increase in revenue for the procedures, but the volume itself, when you're doing 5 or 6 joint replacements a day, there's more efficient use of the OR. The time to the cases are quicker because you're really repeating the same operation, same setup. So it's not like you're doing a shoulder and then you're doing a carpal tunnel and then you're doing a trigger finger, and moving the room around and the tables are in and out. It's just, you ought to have a hip room and a knee room, and you're just bouncing back and forth, and you totally, use the services and everything in the most efficient fashion. And it includes anesthesia and everything else. Even the recovery area is the same because everybody's going through the same process again and again. And I think, we improve patient outcomes because if you do higher volume of any procedure and you repeat those same protocols all the time and refine them, that you end up with improved outcomes from the patient. They're certainly happier in a surgery center, which we'll speak to later, and they definitely have a better experience.
So I'll talk about some drawbacks. There is no reimbursement from payers for this for a 23-hour stay, unfortunately. There are increased costs associated with this program, which would include staff and supply expenses. It can be difficult to staff per diem, so that's why volume does play a major role in this. And it must be managed effectively. If you underutilize the space that you have allotted for 23-hour stay, you don't have a greater margin where you could with maximizing the space that you have. So that you want to manage it effectively and efficiently to avoid those losses. Scheduling certain days where you're doing 23-hour stays. All of that comes into play to manage it more efficiently.
So I'll speak to the outpatient and the 23-hour stay in an ASC. Again, this starts before you build the ASC from a surgeon's perspective. It really starts in the hospital. To begin with, the surgeon themselves has to be realistic about their abilities. A surgeon who takes 2 hours to do a hip or a knee replacement is really not a good person to have in your surgery center doing outpatient or 23-hour stays. So the surgeon, him or herself, has to be realistic about their abilities. And if their ability is such that they can, do efficient work and turn out a very consistent, I hate to say product, but really that's what it is. It's that every operation should go the same way. Every knee and hip replacement should go the same way. Every step should be similar to the operation, our workflow. And the product that you put in the patient should be similar each time. So that there isn't a lot of switching gears and changing and adding and subtracting. And that ability to do that, gives you an operative time of 60 to 90 minutes for every case, and no wrenches being thrown in the process. So you have to have that ability as a surgeon. You have to have the efficient workflow. You have to have a team that you work with that can, manage the patient's pain, control the blood loss, and prevent things like infections and complications. So the surgeon himself or herself has to work closely with the anesthetic team, more specifically in discussing, the types of blocks you're going to use that are long-acting, that will help with the postoperative pain, will help you, mobilize the patient without pain, not block the muscles from working so they can't get up and walk. And a very good multimodal pain management program that are pretty much established around the countries with, preemptive analgesia, where you're giving the patient stuff to block pain before they even have pain, to use no narcotics if you can, or limit the narcotics you use so that you don't affect them afterwards, to hydrate the patients before they walk in the doors so that they're not NPO for so long that they have increased nausea and increased pain. So there are so many things that we do that we learned in the hospital setting that we brought to the surgery center day one that made us successful. So the last part of that slide is just delivering a consistent message to the patient, because learning this through the hospital was the first person that they walked in and saw as they signed him in said to the patient, "I can't believe you're going home after a hip or a knee replacement." And right away, you've ruined the process. So the message has to be from every member of the staff, sometimes down to the custodial staff, that this is great, you're going to do well, this is what we do all the time, we'll get you home, you'll be safe at home, you'll be able to function at home, your pain will be well managed. And then, working again, like we talked about, with the same teams, everybody down to the x-ray tech should be the same, so they know every step of the operation. If you have one member of the team that doesn't know what they're doing, that distracts the surgeon. The surgeon has to watch that person and make sure they're not holding something the wrong way or moving the wrong way in the room. So every single member of the team, down to the x-ray tech who's taking the x-rays during the case, is quite important. So that, as opposed to a hospital setting, having that in a surgery center where you don't have as many people and you have the same team that works with you all the time, has definitely helped us. We've also incorporated the use of robotics. Robotics has helped us to be actually more efficient because it basically creates a workflow that's the same with every operation. Robotics are very attractive to patients nowadays, but we have found that the robotics has allowed us to do the operations more efficiently and more consistently. And this has allowed us to standardize our treatment for most patients for these types of operations.
So just a brief overview of some of our regulatory guidelines as established by the Department of Health, CMS, and AAAHC. So when developing this program, obviously the first thing we did was take a look at, what guidelines are out there. Who talks about a 23-hour stay? CMS, in their conditions for coverage, the Appendix L that governs the surgery centers, it's very brief, and there isn't a lot that discusses overnight stay. But the key point to take out of that is that the expected duration of services doesn't exceed the 24 hours after time of admission. Admission is not well defined, so it leaves you it gives you some leeway to make that definition, and we did that alongside and with approval of the Department of Health. And it certainly talks about the ability to, if you do exceed a 24-hour stay, it should be rare, and you should have it documented as to why. And it could be because, the patient's caregiver was stuck in traffic and wasn't able to get there within the allotted time. AAAHC is probably the body that has the more defined guidelines for 23-hour stay. They have a chapter in their handbook which talks about it. And they address things like the scope, policy requirements, personnel, food service, and incorporating it into your ASC's quality improvement program. And then the Department of Health, you need to do your due diligence because each state may vary, as I said before. And they typically, in our experience, deferred to the CMS requirement, which there isn't much. So we were able to develop a protocol from some of the things that they had mentioned when we initially met with them, and then come back to them with the finished product and get their final approval. So overall, it was actually certainly a learning process for us, and it was a good experience because there weren't many roadblocks since we were, especially in Connecticut, we were one of the first to do it, or the first to do it. And as always, always adhere to the highest standard. If CMS has a higher standard than AAA, you go with that, and vice versa. So your key stakeholders, who does this program have an impact on? Obviously, your patients and their caregivers. There are key things that you need to incorporate into your program, like education. And that starts, like Dr. Buchalter mentioned, at the practice level. When they walk in the door, preparing patients to with the fact that they may be going home or they may be staying overnight, having their total joint replacement at the center, at the ASC, and establishing that comfort for them, giving comfort to the patient and to the caregiver, and then talking about home prep and what that looks like. One thing that we always say is our rooms upstairs, they're very, very nice, but we don't call them inpatient rooms. They're more of an extension of your home. And because we're not trying to create a different environment, we're trying to create an environment where the patient gets comfortable with going home after their total joint replacement. Another key stakeholder are your surgeons. Obviously, if you don't have a surgeon's buy-in and compliance to the program, it will fall apart. And same thing with your staff. Your staff have to buy into the program, and because it will incorporate a different level at your ASC, you have to adjust your staffing models. They will shift. You now have to hire overnight staff, something that is unheard of in an ambulatory surgery center. Anesthesia also, they have to work with you on creating the protocol, adhering to patient selection criteria, changes to your total joint protocol, if there are any, to potentially, include higher acuity patients. And for us, in our case, in the OSSC, we have anesthesia stay overnight. It's not a requirement that it be anesthesia, but we made the decision to move forward with them to stay overnight. And another stakeholder that I didn't personally think about initially is your business insurance provider. We had to do a due diligence on our policies because they were considering us when we initially told them that we would be extending our services to 23-hour stay. They wanted to consider, our existing provider at the time wanted to consider us an inpatient unit, which it is not. So we had to do some shopping around for policies that would allow us to maintain our outpatient status, so to speak. And establishing the right protocol. So these are some of the elements to our protocol that we developed. Certainly, we pulled elements that were required from the AAAHC guidelines, and then incorporated some others with some consulting that we had from people like our pharmacy consultant, infection control, things like that. So obviously you want to establish your policies as they pertain to the 23-hour stay and define things. So definitions like defining the admission time when the clock starts for that 23 hours and 59 minutes. That is a definition because there's no clear guideline on when that time is. You at this center level can define when that admission time within reason will be. The scope of the program and its limitations, clinical criteria, medical records, medication management. The ASC is not equipped with medications that patients routinely take at home. We remain an ASC, therefore we only have medications that are necessary to run the routine services we provide at the surgery center. So having a medication management plan to allow patients to take their own medications from home is necessary. Your staffing model and what that will look like. We decided to utilize 2 RNs who are ACLS trained, as well as an anesthesiologist to stay overnight for 3 patients. Visitation policies. Prior to COVID, we would allow visitors under certain circumstances, and that could have been because the patient lived, an hour or 2 hours away from the surgery center. So we would allow visitation and a family member to stay overnight with them. Obviously, we have not resumed visitation since the beginning of the pandemic. Food services. You at the ASC need to decide if, ordering from a third party delivery service works. That's what we do personally. But there would be other tremendous implications for incorporating a food service program into the ASC. Care of the patient, what that looks like, and quality improvement, including the 23-hour stay program in your ASC's quality improvement program. Could be a QI study that's done, or watching trends and addressing other issues. And then finally, emergency care and how to handle an urgent situation, and what the parameters for that emergency care would be. So one thing I wanted to touch on that is one of the more important elements of this is your staffing implication. As I said before, we decided for our program to have ACLS certified RNs, 2 of them. I think only 1 is necessary, but we decided to have 2. Our overnight physician staff, again, it does not have to be an anesthesiologist, but we had decided to utilize our anesthesia team because we have that level of trust with them already. And then there are implications to your shift changes for the day staff. Your shifts are now evolving from, coming in, at 6:30 and leaving at 4 or 5:30 to on an overnight day, you're staffing a 24-hour unit, and what that looks like. Pre-op staff, increasing the count of your pre-op staff to account for the fact that you need to discharge the overnight patients. And, a physician, the surgeon, the operating surgeon, and or their extender has to come in the next day to discharge their patient. And Dr. Buchalter will touch on that as well. And then your post-op shift, and they have to work later hours to be able to give report to the overnight staff and ultimately transition the patients from your phase 2, so to speak, to the overnight unit.
So from the physician's perspective, to begin with, you don't realize how much goes on in the background in order to make this happen, that there are so many moving parts, not only regulatory, but staffing models and being able to create a seamless program, which Danilo has done. So that for me, it's just like I walk in the door and I do my work and have a big smile on my face every day that everything goes so efficiently and smoothly. But behind the scenes, there was a lot of planning that Danilo went through, and not only from the regulatory perspective, but being able to recruit. I recall in the beginning, just getting the nurses to stay overnight, to find people to stay overnight was difficult. I mean, now we're sort of into it, so it's a no-brainer, but every little thing is like creating the wheel for us, but it's been extremely successful. So from a physician perspective, it's definitely a more efficient use of OR time. If you strictly do outpatient joint replacements and you come into a facility, you can do 2 or 3 of them and get them out the door in time for the facility to shut down at 3 or 4 in the afternoon, then you kind of spend half your day doing nothing else. As a joint guy, you're used to doing 5 or 6 joints a day. So you would be wasting a day in the OR. And if you're limited to 2 OR days a week, you're kind of decreasing your volume, your ability to do that number of joint replacements a year. Also, if you're a non-joint replacement surgeon dabbling in joint replacements, like a sports medicine doctor that does 50 knee replacements a year or something like that, it just opens the door to be able to do those cases and maybe keep them overnight and not be as worried about it. So it definitely makes it easier that you're not diverting patients, that have to, end up going to the hospital, or you're picking patients that are kind of iffy, and next thing you know, you're diverting them to the hospital. So it's a way to avoid those two issues. The biggest thing is to treat these overnight patients as same-day patients. We treat them exactly the same way. Their spinal wears off. We make sure the pain's well managed, nausea is managed. We get them up, we walk them, we take them to the bathroom, we have them go up and down the stairs, and we walk them to their room. Again, we don't call it an inpatient room. It's sort of like a hotel room, but it sort of mimics their bedroom. We walk them to their bedroom, and we spend the evening, getting them up to have them walk and teaching them how to do everything they would do as if it was their bedroom in their house. So by the time the morning comes, they've already done their 150 feet of walking, they've done the stairs, they've been out of bed to chair, they've been to the bathroom, and they feel very comfortable transitioning to going home. It's not a big deal the next morning at 7 a.m. to dress them and have them leave, So this has done a lot for us over the last year, year and a half. It's allowed us to increase the acuity of what we do. So initially we started with BMIs of less than 35, no sleep apnea, no diabetes, non-smokers, really the cream of the crop patients to do, which really limits the amount of patients you could do, because, there are very few patients that are not obese in the United States. But in essence, we've increased our indications. Our BMI is now 40, and sometimes we can do even higher depending on the patient themselves. We have negative pressure dressings that we put on these patients to prevent wound problems. We definitely take care of managed diabetes now. They bring their medications. We do the blood sugars. We have no issues with that. We do our obstructive sleep apnea patients. So those patients who have CPAP machines, or any of those patients with the sleep apnea, typically would never do as an outpatient. It's like roadblock number one, red light number one. Now we do those patients. They bring their CPAP machines with them. We monitor them overnight, and we have no issues. So from that perspective, it's been amazing. Having the setup with the nurses and the anesthesiologist staying overnight. When you're talking to the patient in the office and they walk in and they say, "Doc, with COVID and everything, I really don't want to be in a hospital." You have the opportunity to present an alternative to a hospital, and that's been a very big thing. But in addition to that, when you tell a patient, "Listen, you're going to go to a center where we do joint replacements. We don't take care of sick patients. We don't take care of infections. There's no infections allowed in our door here. We basically cherry pick our patients. So we will have a lower complication rate, lower infection rate here. It's not as high a volume institution as a hospital will be. You're going to have 2 nurses taking care of 3 patients versus 1 nurse taking care of 6 patients in a hospital. The anesthesiologist is going to be 2 minutes away from you. It's very easy for the patient and the patient's family to buy in and to be very excited and very confident.
Right. And just to add too, I think we were fortunate in the surgery center here in Danbury, because we, not only do you have buy-in from the surgeons and buy-in from the staff, but you have to have a very good management team. And, our director of nursing was instrumental in getting this thing going, and her buy-in was more important than mine. And we also have a very good management company, Merritt Healthcare, who was on board from day one, from incorporating the 23-hour stay rooms into the plans of the surgery center, into the recovery area, to helping us get this off the ground and meeting with the Department of Health with us. So it's really, you have to have not only their buy-in, but their support and their assistance, because we would not have been able to get this going if it weren't for the management team, and both from the management company and at the center level, and certainly the surgeons. So finally, some brief financials and statistics at the OSSC level. And, obviously, I think a lot of people ask, is this worth it? Is it worth the financial implications. So certainly, as we touched on earlier, there are increased costs that come with starting a 23-hour stay program. Again, lack of payer reimbursement. Your staffing costs will certainly increase. You have to pay a stipend to your overnight physician who is on call, staying at the center, and provide an on-call room, which we do have. Food service, although minimal, it is still an increased cost. Linen as well, minimal cost, but something to be considered because you have to contribute for extra linen, but also when it comes to capital outlays for equipment, for example, your overnight beds. We don't keep our patients on stretchers. We transition them to a comfortable hospital bed. And so there's, linen associated with those new beds that would not have been needed for stretchers, certainly. And so there are all these things to consider. So our volume at OSSC, the original projections accounted for about 60 total joints in year 1 and 95 total joint replacements in year 2. So as you can see, in 2019, which we started total joints at a slower pace in April of 2019, started our 23-hour stay program in July. We did about 45 total joints in that year. So from roughly the end of April to December, we had 20 outpatient joints and 25 23-hour stays. Then in 2020, despite our closure due to the pandemic, we increased that volume tremendously from 20 outpatient joints to 72, and from 25 23-hour stay joints to 164 in 2020. And fast forward to now to 2021, we are annualizing to 195 outpatient total joint replacements and 255 23-hour stay joint replacements. So that's a tremendous leap from our original projections. And I contributed to not only the 23-hour stay, certainly it has a major part, but our surgeons who have not, so Dr. Buchalter came in, with the having established an outpatient joint program at the hospital. So he was ahead of the curve. But we had other surgeons who really did not want to do any joint replacement at the ASC because they hadn't established their own total joint protocols for themselves. And I think Dr. Buchalter talked about that earlier with having surgeons understand their own individual abilities. But because of the 23-hour stay program, that has opened the door for some of those surgeons to get comfortable with the notion of doing a joint in the ASC and the ability to keep them overnight.
And then as they have become more proficient at doing their joints with the 23-hour stay, they realize that, some of these patients really can go home. So they've transitioned to not only doing the 23-hour stay, but also doing the outpatient joints. So we have seen that change in those surgeons that don't do as high a volume, and that their confidence level of being able to do not only a 23-hour joint, but an outpatient joint, has grown out of that. So having that conduit of the 23 hours allowed them to transition to outpatient joints. And that trend has continued as you can see volume-wise on the next slide and percentage-wise.
So some revenue statistics. In 2019, 62% of our total joint revenue came from the 23-hour stay program, and 38%, so 1/3 approximately of that revenue came from the outpatient joints. That same trend carried over into 2020. And then in 2021, because of the increased amount of surgeons who are getting more comfortable doing their joints at the ASC, we're seeing, that start to shrink and start to equalize with the amount of 23-hour stay and outpatient patients. But as a percentage of total revenue, in 2019, 160, almost 161%, we saw an increase in almost 161% in revenue because of the 23-hour stay. That increased in 2020, where we saw 191% increase in revenue because of the program. And in 2021, that has decreased, but only because it's allowed us to increase the number of overall total joints being done.
Yeah, and I think to speak to that is that, when we're looking forwards to 22, 23 and beyond, things that are feeding the program are the fact that we can now do our Medicare hips and knees at the center in a way that it is profitable. And a lot of those patients, do not want to go home the same day. You have your 70-year-old that comes in the door and says, listen, my friend had a stay and my buddy said, don't do it. You can't go home the same day. So that allows us to take those patients and do 23-hour stays. So age-wise, we're doing patients in, healthy patients, obviously, into their 80s. And, an 80-year-old as an outpatient is a little scary, but a 23-hour stay is certainly a very successful thing to do. We've also looked into the future to say, okay, we have these patients that, that we have our 80%, but what about the 20% of the patients that we can't do as 23-hour stays? So we are looking into, somebody needs 3 to 5 days. They don't have a caregiver at home. They don't have the confidence. Maybe they have some comorbidities that would prevent them from a 23-hour stay. And presently we can't go from a 23-hour stay to a rehab facility. So we can create a different model, like a medical home model, where we would have 3 to 5 beds where these patients can stay and have outpatient services brought to them, like physical therapy, visiting nurse, as if they went home. So kind of a conduit or a way to extend our 23-hour bed to a contiguous facility where we can really manage these patients, because it's pretty obviously with cost containment and things moving out of a hospital that this is really our future, and trying to prepare and stay a step ahead of the game is what we've been doing.
Exactly. And, it also opens up the surgery center. The 23-hour stay program can potentially open up the center to other specialties. I mean, if, we focused a lot on total joints. We also have a pretty robust spine program. And, in your ASC with a 23-hour stay, you can incorporate other specialties like spine, breast surgery, and others that may, want the ability to keep their patients overnight. And with that, we are finished, and I want to thank Dr. Buchalter for doing this with me. And I also want to thank the team at Garfunkel and all of you. Thank you very much.
We appreciate it. Thank you very much. Danilo has been a great partner through this, and we've certainly learned a lot, and sort of look forward to the future together. Thank you.
Thank you.